So I usually joke about covering all of the core competencies, but actually we may cover all of these today. So just some disclosures, and I will draw your attention to the first two. So GW Pharmaceuticals and Insys Therapeutics have provided research support to me and UCLA, and they are the two principal manufacturers of pharmaceutical-grade cannabinoids for treatment of epilepsy. And I want to show you a video of infantile spasms to remind you what these look like. Okay, so that was it. Pretty dramatic. That was a pretty violent one if you look at the spectrum of infantile spasms. And it's just a head drop. And these happen in clusters, and you can see the mom knows the next one is coming. She's got her hand out ready to catch the child's face. And these are, of course, nothing like what we usually think of when we think of seizures and epilepsy. We think of an adult usually who falls to the ground, loses consciousness, is violently shaking and convulsing. So infantile spasms are relatively subtle in comparison. But the result is not subtle. So when you look at the world of infantile spasms, it's disastrous because this disorder is usually devastating, more often than not. And the reason it's devastating is not because of those subtle seizures. It's because of changes in brain waves, at least what the brain waves are telling us about the brain. So this is a relatively normal EEG, and folks who are used to looking at EEGs can look at this and identify parts of the brain, the front or the back, based on the height or the frequency of brain waves. There's an organization that we expect and see. But in infantile spasms, it looks like this. And this is similar to what we see in a variety of epileptic encephalopathies, where the seizures are just frankly devastating. And the chaos you see in this EEG mirrors the chaos that is happening in the brain and what prevents development, prevents learning, prevents these kids often from going to regular school, from walking, talking, etc. But the bright side is that sometimes we can cure these kids and they can be normal. Okay, so the worst case scenario, which is often the case, is that these kids are devastated. Mental retardation, so IQ is less than 70, severe lifelong epilepsy. So the infantile spasms might not continue for their entire life, but they are likely to have other forms of epilepsy that continue to threaten them. There's substantial risk of autism. There's substantial risk of death from seizures. And there are a variety of secondary costs, like parental underemployment, lost time from work, the costs associated with taking care of a child and later an adult who can't take care of themselves. The treatment options for infantile spasms are not pretty. Corticosteroids and ACTH are generally first line throughout the world, and we use unusually high doses. So when it comes to corticosteroids, we use about 60 milligrams per day, so that's a high adult dose. And it's about 50% effective. There's about a 30% relapse rate, and it's associated with severe immunosuppression, and small infections like ear infections can turn into big infections. And we've had 2 children die at UCLA. The only other FDA-approved medication is vigabatrin, and it has a reputation for being decently effective, maybe 20% response rate in our experience with a 30% relapse rate. And there is this specter of potential vision loss, which is definitely the case in adults, where there's approximately a 30% risk of irreversible peripheral field vision loss. And the rest of the reality is that there are a whole bunch of other drugs and therapies that generally don't work. Surgery is an option for a select few patients who have a discrete lesion in their brain, which can be taken out, but that's rarely an option. There's some belief that the ketogenic diet is effective for some patients, but that has not been our experience at UCLA. We are trying to publish our experience right now where we tried it in 22 consecutive patients, and our batting average is 0. Okay, so what we're going to talk about today is specifically cannabis. So we're going to talk about the history, some definitions, which chemicals we think might be acting. We'll review the data. We'll look at pharmaceutical approaches and some future aims. And before we begin, I've kind of gotten this reputation as being a medical marijuana-friendly doctor. And I would rather be known as medical marijuana curious. And I want to emphasize that we're not just doing marijuana research, that this is an integral piece to a diverse approach where we're looking at comparative effectiveness and cost effectiveness of a variety of the therapies that we just mentioned, because we need to make sense of what's already out there. We're looking for biomarkers that might predict outcomes, things in EEG, metabolic markers. We're trying to look at genetics and sequence every single infantile spasms patient at UCLA and try to identify genetic predictors of response to particular therapies or genetic predictors of non-response. And we're trying to identify barriers to care. You know, what is preventing kids with infantile spasms from getting to UCLA or other centers where there are available treatments for infantile spasms? I'm going to tell you, we're conducting a survey right now. We've interviewed about 50 parents of children with infantile spasms, and the number one problem is maybe folks like you. So it's pediatricians who see videos or hear stories of movements like what was seen in that first video, who don't get those kids to referral centers quickly. And if you don't get kids to referral centers quickly, the limited medications we have don't work. But it's a tall order because, of course, a lot of normal kids do funny-looking things. A lot of kids have gastroesophageal reflux. There are a lot of reasons to get fooled. But my hope is I can entice you and threaten you to have a low threshold for referring these patients, because we would much rather see a whole bunch of normal kids getting unnecessary VITA EEGs than one or two kids being seen months, sometimes years after the onset of infantile spasms, at which point there's no hope of a meaningful treatment. Okay, so let's talk about marijuana. So there are two species, cannabis sativa and indica, and according to Wikipedia, they look like this. So sativa is tall and skinny, indica short and stout. Sativa has thin finger-like leaves, indica is a bit thicker. Also, according to Wikipedia, sativa is more activating, indica is maybe more calming. And marijuana is not just the recreational product that we all know. It is a plant that is used to make lots of things, including various paper products, textiles, even biofuel, if you believe this. This is a marijuana cigarette. This is a marijuana cigar. And there are all sorts of preparations out there. My favorite is the lemon shortbread tart in the bottom left there. But we're not going to talk about these things today. Usually when you think about medical marijuana, you think about a kind of back alley establishment like this. But these days, they actually look more like this. And what they didn't show you is the armed guard, who is not pictured. And remember that right now, medical marijuana is a cash-only business because it's federally illegal, and federally chartered banks don't want to do business with organizations that are selling illegal products. So this is a cash or check type business. These establishments have huge stores of cash, and that's why they have guards, and it's potentially a dangerous place. But we will be talking about products like those pictured here. So these are oil extracts that are derived from plants bred to have various cannabinoid constituents. We'll also talk about some pharmaceutical approaches. And these are largely oil-based extracts that are administered by mouth to children with epilepsy. And you can see there's a kid with Lennox-Gastaut syndrome who has frequent seizures that result in falls and head injuries. That's why he's got the helmet. And then there are things like these. This looks like candy, right? Looks kind of like a Tootsie Roll. And if you believe the markings on the package, it contains various cannabinoids, and that you should always consult a physician for recommended dosage, and you should keep away from children, right? This candy-like package. There are lots of, frankly, crazy things like this on the net, and when you start searching, you will find some incredible claims about the efficacy and safety of these products. Things like this. This is pretty typical. A little bit disturbing. Okay, so marijuana has been around forever. It spread worldwide. And when you think about reports of the potential medical use of marijuana, they date back to 3000 BC in China, using it to treat things that, from our reading of those records, may be rheumatologic illness. In the Middle East, in the Middle Ages, it was used to treat things that sound like epilepsy. So this is not new. It really made it to the West in the 1800s and was used principally as an analgesic. And of course, today it's used everywhere for everything. I like this graphic. This came from medicaljane.com, and it describes what's been going on in California. So California was a trailblazer of sorts, being the first state to approve medical marijuana back in '96. And actually just this month, Governor Brown signed a trio of bills that are intended to formalize rules for the packaging, sale, distribution, taxation, licensing, and even the environmental impact of medical marijuana. It's probably important given the drought, and most forms of medical marijuana need a lot of water. So the medical marijuana industry is hurting. And when you look nationwide, there are just 2 states where recreational marijuana is legal. And when you look at those that already have medical marijuana on the books, there are more green states. There are several more that have specific types of medical marijuana that are approved. So these are CBD or cannabidiol containing marijuana. We'll talk about that. There are several where its legislation is pending. There are only 5 states where it's illegal. But remember, it's illegal everywhere because it is still a federally illegal drug. Okay? When you look internationally, there is supposedly only one country where recreational use is legal. And if you believe the Huffington Post, it's North Korea. I tried to verify this on Wikipedia as well, and I couldn't get an answer. But medical marijuana is approved in a variety of countries, the dark green, and then it is decriminalized in many others. That's the light green, and medical marijuana is approved in most of those countries. Okay. Now, there have been rumblings of the potential utility of medical marijuana for treatment of epilepsy since about 2009, 2010, and there had been scattered reports for the last 20 years suggesting a possible role. But things very much changed when Sanjay Gupta changed his mind, and he detailed this in a trio of documentaries, first in 2013, subsequently 2014, and more recently this year, where he profiled a number of patients who have received medical marijuana products for treatment of their epilepsy. And foremost was this little girl. So her name is Charlotte Feige. Her case has been well described and documented in the literature. She suffers from a disorder called Dravet syndrome, which is a generally pretty bad kind of epilepsy. These are kids who have many seizures per day, despite all of our best therapies. It's often accompanied by mental retardation and other degrees of cognitive impairment. And she gets her product from this band of brothers. They are quite photogenic. And they produce this particular strain of medical marijuana that they've named after that girl, Charlotte's Web. Good marketing choice, I'd say. And they operate through a nonprofit that is associated with their dispensary and growing operation. It's called the Realm of Caring, and they have gotten a lot of attention. This is what Charlotte's Web looks like today. Looks pretty legit, right? This is a polished product. It looks like medicine. Okay, so let's talk about marijuana. There are 2 key cannabinoids among hundreds of others. The one we know best is delta-9 tetrahydrocannabinol. This is THC. This is the component that is associated with the usual symptoms or effects of marijuana that we usually think of. So euphoria, hunger, paranoia, other psychiatric effects, amotivational syndrome. The other big one is cannabidiol, or CBD, and this is the one that we think might have anti-seizure properties, may cause sedation, may cause anorexia. And there are 2 known endogenous cannabinoid receptors in the body, CB1 and CB2. CB1 is mostly found in the brain, CB2 elsewhere in hematopoietic tissues. It's a transmembrane protein. It's G-coupled. It does a lot of things. The spectrum of activity is growing every month in terms of our characterization of what it might do. These are the 2 endogenous endocannabinoids that are most populous. There are an expanding list of these. There are about 7 now. But you'll see they look nothing like THC and CBD, which is interesting. We know that THC agonizes CB1 and CB2, and we know that CBD does not. And in terms of its mechanism, we've seen that it has some potential effects in neurons that might have a link to anti-seizure effects. But the bottom line is we simply don't know what it does. Now, there is some growing evidence in vitro and in vivo that cannabidiol is effective against seizures. And I won't go into too many details, but there is a growing list of standard seizure models for epilepsy in which cannabidiol exerts dose-dependent effects in which it reduces the frequency of seizures, the spread of individual seizures, the number of animals that die with seizures. And it seems to be pretty well tolerated. So this is a rotorod, and you stick the rats on this, this spinning device, and you see how long they can hang on and whether or not they fall off. And the rats do pretty good. This is in contrast to a lot of classic anti-seizure drugs that are quite impairing, things like phenobarbital, phenytoin, tegretol. This is a rat balance beam, and the rats do pretty good. So although there is what appears to be a dose-dependent increase in the number of foot slips, they call, grip strength is preserved, and all of the rats make it across. That's better than most known and established FDA-approved seizure drugs. Okay, one problem, though, is that a lot of this evidence has come from a single group, and their lead author has reported stock options in GW Pharmaceuticals. So it's one thing to do research that is funded by pharmaceutical companies. I do that myself. But it's a whole nother thing to have stock in that operation. So it introduces some potential bias. It introduces some suspicion that maybe this isn't true. But there have certainly been other investigators who have produced not quite as compelling evidence of efficacy and safety in animal models. So what do we know about human data? So back in 2013, around the time of that Sanjay Gupta special, Brenda Porter and Catherine Jacobson from Stanford and UCSF conducted a small internet survey where they looked at a Facebook group of parents who were administering these products to their parents. And they saw that the folks who responded to their survey reported dramatic success. And this was a group that had a lot of patients with Dravet syndrome, that's the DS along the left there, and a variety of other epilepsies. But across the board, they were seeing dramatic benefit in a type of epilepsy that we frankly find very hard to treat and that we are seldom effective. So I saw that, that CNN special with Sanjay Gupta. I saw this survey, and it's frankly kind of encouraging. I am pretty darn desperate to find effective therapies for these children. So we thought, well, it's not that hard to do our own survey, and why don't we just target kids with infantile spasms and Lennox-Gastaut syndrome? So that's exactly what we did. And we advertised this survey on a variety of foundation websites. And what did they tell us? They told us kind of the same thing, that far and away, the vast majority of patients, upwards of 90%, had meaningful reductions in seizure frequency accompanying relatively low doses of these cannabidiol or CBD-enriched cannabis extracts. 13% were seizure-free. Now, this is a group of people who had failed numerous therapies, and who, if they showed up to my clinic, my instant honest thought is that there's little hope that I can help these kids. We looked at Dravet syndrome, which is also called severe myoclonic epilepsy of infancy, and we saw a similar trend. We looked at all other types of epilepsy in this survey, similar trend. So on one hand, you might get really excited about this data, that it is working for everything. But on the other hand, when it works for everything, you also wonder if it's working for anything. And that's our job, to separate what is actually effectiveness here, what is a placebo-like effect. Is this really just mirroring the hope of parents trying something they believe is effective? My guess at this point is that it may indeed be effective, and that these astonishing response rates really just reflect placebo effects and hope. And we just need to distinguish those two and find out how effective it is, if it is effective, and how safe it is, if it's actually safe. In our survey, it was quite well tolerated. The only side effects that we saw that were more frequent during CBD use than before were an increase in appetite and weight gain. But there are some interesting studies now. So Colorado has certainly been a hotbed of medical marijuana use and recreational use more recently. And they have a lot of patients who have come from long distances to marijuana to get, long distances from Colorado to get access to these CBD-enriched extracts. And they found a bunch of patients who presented to Children's Hospital of Colorado and documented what the parents said were response rates, and they were pretty good. And they saw specific efficacy for infantile spasms, for Lennox-Gastaut syndrome, in addition to Dravet syndrome. And they had a little more than 70 patients. About a little more than half were already living in Colorado. The other half moved to Colorado to get access to these drugs. And what would you think? The efficacy should be the same no matter where you came from, right? Well, it was only 22% effective if you already lived in Colorado. But if you were motivated enough to move from another state or another country to get access to these products, your response rate was more than double. So that certainly makes us wonder that some of this efficacy data is hope. Okay, so so far we've been talking about these CBD enriched cannabis extracts, and now we're going to switch gears and talk about what is going on in the pharmaceutical industry. So these are the two companies that are making the most success bringing these products to market, we hope. So GW Pharmaceuticals has a product called Epidiolex, and it's derived from a plant. So there are multiple plantations in the United Kingdom, and they are bred to have lots and lots of CBD and very little THC. And it is further purified to make a product that's about 98-99% pure. It's marketed as Epidiolex. Insys has a synthetic cannabidiol, so it's never touched a plant. It's made in a laboratory. It's essentially pure cannabidiol. And the GW Pharma product is already in a pair of phase 3 trials each for Dravet and LGS. We are hopefully going to begin a couple of these studies soon. There are phase 3 trials for the same disorders planned with the Insys product. Those are upcoming. There is a compassionate use study that has been going for about more than a year with the GW Pharma product, and we're hopefully going to start this in the next week or two. We finally surmounted all of the hurdles, from local UCLA hurdles to the FDA, DEA, Department of Justice. It's a long list. And we will be using the Insys product in a kind of first ever clinical trial for infantile spasms here at UCLA, hopefully in about a month. So what has been learned about this data? So the most compelling data has been from this compassionate use study. So there's been an effort to use the expanded access mechanism of the FDA to give these drugs on a compassionate use basis. Each academic center that is able to surmount the regulatory hurdles is limited to 25 patients. And so far there have been 123 patients who have been on this product for at least 3 months, and their median reduction in seizure frequency is about 46%. So pretty good. And when you look specifically at Dravet syndrome, it's a little bit better. When you look at Lennox-Gastaut syndrome, it's equally good. The problem is we have no idea what the placebo rate is, because this is a compassionate use study. There's no control group. Responses are based on parent reporting. So they keep a diary, and we keep track of the seizure frequency in that diary. They saw that it was similarly well tolerated, which is what we have seen in the surveys and in the experience of parents using these CBD-enriched cannabis extracts. And when you look at this accumulated data, it's interesting to look at the doses. So when you look at these surveys of people using these community CBD-enriched products, they're using relatively low doses of CBD, about 4 milligrams per kilogram per day, whereas in the pharmaceutical studies, they're using 5 times or 10 times the dose. And yet the response rates are lower with these high-dose pure formulations. So that makes us wonder, is there something going on with the dose? Are the response rates in these surveys highly inflated? Still not clear that the drug is effective from this data. And when you look at the quality of the data, you can see that none of these studies have the things we look for, like randomization, blinded outcomes, placebo controls, unbiased verification using EEG. And now let's take a step back. So when you look at marijuana that was first growing thousands of years ago and was untouched and unbred, it was about 50-50 mix of THC and CBD. But when you look at most recreational marijuana around today, it's been bred to have tons and tons of THC and very little CBD, because THC is that psychoactive product that we're looking for. Medical marijuana is the same, most medical marijuana. But what we're talking about today is different. So the medical marijuana that we're looking at is CBD-enriched products. So it's the opposite. Lots and lots of CBD, very little THC, very little psychoactive effects. The kids that are using these products for treatment of epilepsy are not getting high. And when you compare this to the pharmaceutical products, of course, those are almost pure CBD products. Okay, so let's talk about some risks. The big one when we talk about these medical marijuana products is consistency. There's probably tremendous batch-to-batch variation, and we've seen that on a limited basis in those few instances in which we've been able to test these products, look from batch to batch, and we've seen sometimes huge swings in the CBD content, sometimes a doubling of the content from month to month, sometimes having a batch that has no CBD whatsoever. We have no idea what the shelf life of these products are, and there are not great ways to test the product, but there are ways to test it. Okay, so this is the website of an organization called The Workshop. They are local here in Pasadena as well as other locations along the West Coast. And for about $100, they will take your sample of medical marijuana and they will test it and they will characterize the cannabinoid profile. And they'll give you a little sheet that looks like this, and I'll zoom in. So they'll tell you all the different cannabinoids that are in there, and you can verify with some degree of certainty whether the content of your medical marijuana is actually similar to the labeled or advertised content. And in short, we've seen that it's often different. For an extra fee, you can also check for things like mold or contaminants, pesticides, solvents, toxins of various sorts. So there was an interesting letter to the editor in JAMA in June, and there was a group using this laboratory, the Workshop, and some collaborators from Johns Hopkins and Penn, and they went to 3 cities on the West Coast to buy some medical marijuana. They went to Los Angeles, San Francisco, Seattle, and they simply tested it all. And they saw that the vast majority of products were mislabeled, that they had at least a difference of 10% of advertised cannabinoid content. Most of them were over-labeled, meaning that the producers or distributors were overestimating how much THC or CBD was in the product, and that many products had no cannabinoids whatsoever. This was interesting. So this Pasadena business that could test your pot was shut down, and a couple people were arrested, including the second author of that letter. And they were allegedly producing a controlled substance. That's all we heard. Haven't heard any follow-up as to whether there was a conviction or anything like that. But it highlights that we are proceeding in at least legally precarious waters here. Okay, are there any medical risks? I would say there certainly are, despite what you read on the internet. When you look at the internet, this is an effective product without question. It's a safe product without question, but we simply don't know that. There's almost no safety data aside from what we've seen in the compassionate use study. But we know there are drug interactions. So this was just looking at co-administered anti-seizure drugs, and we saw that there were often quite big swings in the serum levels of drugs like clobazam. And that's because CBD is a potent inhibitor of the CYP450 system, and in particular the 2C19 and 3A4 enzymes. And that in particular affects clobazam and its active metabolite. So we have seen that blood levels of clobazam and N-desmethylclobazam can rise 100%, 200%, sometimes 1,000%, 10 times. In some patients, and in other patients, there's no change. So we haven't been able to figure out this conundrum. But this makes you think that some of the efficacy that we see with these products may be because CBD is simply increasing blood levels of an effective drug, an effective FDA-approved drug, and maybe it has nothing to do with the CBD. But that said, there have been favorable reports in kids who have been using CBD alone, who have been successful in tapering off clobazam and other drugs that might be influenced. So we're not sure. It also affects lots of other anti-seizure drugs. It also affects drugs that you might be using, things like warfarin, tricyclic antidepressants, SSRIs, beta blockers, corticosteroids even, aspirin even. These are drugs used by lots of our specialists in this room. Are there any legal risks? So remember, this is still a Schedule I, so the DEA classifies this drug as having only the potential for abuse and no medical benefit. So as far as the federal government is concerned, the cultivation is illegal, distribution is illegal, the use is illegal, and their official dictum is that smoked marijuana is not medicine. Okay, so this is an unusual pairing of a libertarian and a liberal. So this is Rand Paul and Cory Booker, and they co-sponsored a bill back in about March called the CARES Act. So it's Compassionate Access, Research, and Respect States' Rights. Well, it's an interesting title and an interesting goal, but what they sought to do was to move marijuana to a Schedule II drug to join other drugs like cocaine. So drugs that do have some potential for abuse, but have some potential recognized benefit. And to divorce cannabidiol or CBD from marijuana completely. And the effect here would be that it would vastly simplify our efforts to study this drug. So to give you some sense, we've been trying to get this compassionate use study going at UCLA for almost 2 years. And we think we are close. And it's taken more than a year for a couple other studies that are also close. This is vastly disproportionate to other clinical studies for epilepsy drugs. In most other drugs, there is almost no wait. But this bill, despite its bipartisan support, suffers from bipartisan opposition. And it's essentially dead. It's been sitting in the Senate Judiciary Committee for almost 6 months. So what is the UCLA policy? Most people don't know the policy because it's not advertised. But use of cannabinoid-containing extracts in the hospital is absolutely forbidden. And that is for a generally good reason. We don't know what is in these extracts. We don't know about the consistency. We don't know about the quality. We don't know about the safety. It makes sense that we would be wary of using these products. In the event that one of our patients is taking one of these products and they come to the hospital with a dangerous increase in seizure frequency, we don't give the CBD extract. We give them things like benzodiazepines, Ativan, diazepam, et cetera, et cetera. And that makes sense because if they're coming to the hospital with a whole bunch of seizures, doesn't it suggest that their extract is not working? Seems like a fair policy. Okay, so let's do some cases. Number one, we've got a 3-year-old girl with long-standing infantile spasms and tonic seizures, having failed adequate trials of 11 anti-seizure therapies at appropriate doses, including the ketogenic diet. They had used medications that were high risk. And then within weeks, on a low dose of this extract, came in for video EEG because I was dubious. But we didn't see a single seizure in 24 hours, whereas this kid had been having hundreds of seizures a day. And the EEG background looked better. And this was in the eyes of my colleagues who are appropriately skeptical. She even seems more alert when you see her in clinic. Okay, so what are we going to do? Why don't we ask the residents who are hiding in the back? Any bold volunteers? Are you going to call Claudia Wong? Are you going to stop this extract? Are you going to continue the extract? Look the other way? Call Senator Paul? No, wait. I can hear the crickets. How about someone more senior? No, still silent. Well, I'll tell you what we did. So we looked the other way. We continued the extract. And as of last month, she is 11 months seizure-free. Okay? Oh, before we do that, it makes you wonder, what would she have been like if we had started this extract earlier? I don't know. She's pretty devastated. She doesn't walk or talk. She can't sit by herself. And maybe her development would have been bad because she had other brain issues. But it makes me wonder, we have a huge population of patients with infantile spasms at UCLA, nearly 400, and the ones we see in clinic are not doing well by and large. Okay, case 2. We've got a 4-year-old boy with video EEG proven absent seizures. He was offered multiple approved and generally safe FDA options. Parents declined all of them and started a CBD extract instead. He shows up in clinic 7 months later. Seizures are almost gone. He wants a second opinion. So now we're talking about a kid who is doing fairly well, is cognitively pretty good. He's never tried an approved safe medication. You're going to see, you have already seen many of these patients in the hospital and already made these decisions. So let's get someone confident. So why aren't you going to call DCFS? Everyone in this room is a mandatory reporter. This is an illegal, illicit drug. Are you not legally required to call DCFS? You absolutely are. Has anyone done that at UCLA? Raise your hand. No, I'm aware of no cases of this happening at UCLA. It has happened at several of our close-by hospitals. Would you stop the product? doing pretty good. If you don't stop the product, aren't you aiding and abetting now? It's one thing to not report. It's a whole nother thing to support the use. Would you titrate it? Because he's almost seizure-free. Someone's got to commit. Oh, we got a hand. So the question was, shouldn't you try something that's FDA approved first? Absolutely, but the parents won't do it. That's not one of the options on this list, right? Your follow-up? Well, they won't stop it. You can look the other way, and that is option D. Yes?
If he's doing so well, why is he here for a second opinion?
They're nervous.
Nervous about what?
They want to know.
Did you see that?
No, they're not worried about that. They heard I was a CBD-friendly doctor. So if we report them, if we stop it, they're certainly not going to be our patients anymore. They will go to Child Protective Services. They can maybe taken away from the parents, maybe appropriately. We looked the other way. We continued the product, and it stopped working. And they came back, and now he's on levetiracetam, and it's not working. But he's still our patient. And I don't know if that was the right move, but it at least keeps him within the oversight of UCLA, where people are aware of competing therapies, where we're aware of the risks, we are aware of the promise. And I don't think we should just punish these parents in their well-intentioned attempt to help their children, but it's not without risk, and it's not without legal risk. Good one. They titrated the dose by themselves first, and that still didn't work. But that was ammunition to taper off completely and try a new medication. But we're still not successful. Another question.
I'm sure you can buy all these products online. Parents can find them.
They're really hard to buy online, technically, but you can find out where to get them online, certainly.
Okay. And then, what about along with look the other way? Like, there's some quality control thing. As somebody who knows about these products, do you actually look at what CBD product they're taking? Do you have?
Are you allowed to hold these products in your own hands? Nope. So I'm not collecting patient samples. We're not testing them ourselves, but we encourage patients to go to these quasi-legal labs that are local and that will charge you a couple $100 to characterize your product. But if you wanted to be rigorous about this as a parent, you would want to check serum blood levels of other anti-epileptic drugs. You'd want to check every batch before you give it to your kid. And for most people, this is hard to do. I mean, for one thing, you are, to some extent, publicizing your use, creating a paper trail. I think a lot of parents are afraid. It's also costly. So the cheapest tests are about $100 each. So that means every month you're spending $100 just to verify that your product is what it's advertised to be. And when you look at the cost of the product, it's astronomical. This is, for most kids who are 20 to 30 kilograms, to get what is considered a typical effective dose, we're looking at $500 to $1,200 per month for just the product alone. And if you're going to test it now, you're looking at another $100 to $200 every month. And to test the product, they actually need fairly large quantities, so you're spending extra on that front too. So the reality is that most parents are not doing this. There are a few who do, and that has been useful in seeing which manufacturers are more or less trustworthy or more or less making decent product. But the reality is that none of them are very good, and we're typically seeing swings of 20, 30% every now and then. Sankar.
On this multiple choice, I just want to make a comment. Choice C, that stop CBD immediately. If you don't do that, I don't think you're against the law, because you didn't really prescribe it. They made a choice. Okay? Secondly, the difficulty with their choice, really not your choice, the legality is more because it's a Schedule I drug. people are within their rights to choose to treat themselves or a family member, you know, with a medication that is not FDA approved. Okay? We have always had patients who have used drugs that are now FDA approved in the United States, but have gotten it from Europe or Canada. And the only thing they had to sign in order to was that it was not for commercial sale. The FDA doesn't actually say whether you may use something personally. They only say whether you can promote it and sell it. So I just want to make sure you guys understand. It's not illegal if a parent chose to give a drug that's already proved to work elsewhere.
Mhm. Correct, but that's not our situation, right? It's not proven to work elsewhere.
It's very tricky because there is an approved cannabinoid product. You saw the pharmaceutical when we focused on the CBD. The GW has a product in UK that's called Sativex that's approved all over Europe for multiple sclerosis, for spasticity of pain. It is 50-50. So it's not even true that it's not entirely regulatory. So there's a lot of dimensions to this issue.
So I also chose choice E. So we called Senator Feinstein. This is what she said. I recognize that marijuana may have medicinal properties. I have supported compassionate use. I believe it's important to conduct further research. So this sounds like somebody who would support that CARES Act, right? Well, she does not support it. She has not publicly come out for or against it, whereas Senator Boxer has. She's in support of it. And Senator Feinstein sits on the Senate Judiciary Committee, which is presently sitting on this bill. Case 3. We've got a 2-year-old with infantile spasms, multifocal seizures. He's doing terrible, but he seemingly had a good response to CBD-enriched extract, according to the parents, with a dramatic reduction in seizure burden. You're not so sure. This one doesn't look like he's much more alert or behaving differently than you'd seen him in the past. And he's admitted to this hospital with sepsis. He's still taking the product. Parents have the product in their possession, in the room. Same choices. Before we were talking about outpatient. Now we're inpatient. And you know the official policy, right? Official policy is you stop the product.
Question is, on some of your other cases, one of the options was titrate down versus stopping it immediately. If you're faced, I mean, if you took a setback in the outpatient setting, the kid just wasn't doing well, and you were like, kind of trying to advise them as to what to do, is it unsafe to stop immediately, or should they titrate down?
Very good question. We don't know if it's effective, but if you believe for a given patient that it's effective. So that first case where we had tried everything and this kid was suddenly doing well, I'd be pretty darn uncomfortable stopping that drug.
I'm saying if they're not doing well.
If they're not doing well,
Yeah, and cold turkey versus. Yeah, that's what I'm asking. Is the kid's doing great? I keep on going, but the kid was doing well, and now just like it doesn't seem to be effective anymore. That you're titrated up appropriately, and the parents are considering stopping. Do you stop cold turkey, or are you supposed to titrate?
I have no idea. We've stopped at cold turkey and haven't encountered a catastrophe. But you have to also think about other drugs that are co-administered. So if they're getting aspirin or corticosteroids or clobazam and you stop at cold turkey, you're likely to lower those blood levels of those other drugs. So you may encounter other unintended consequences. Okay, but now we're in the hospital and you got to make a decision. You can't just do, just doing nothing is choice D. So if you want to just do nothing, you're going with choice D. Do you document this in Care Connect? Well, when you try to type it in under medications, it can't find it. So you can maybe try to use that excuse. But I would encourage you to document it because the FDA is not going to come after you, but the DEA might. And they might seek to make an example of somebody who's clearly breaking the rules. They want to find the cowboys, especially if something bad happens. So I would say document what the patient's taking. Document that you have discussed with them all of the medical, legal, regulatory risks and limitations. and then make a decision that you think is in the best interest of the patient. So in this case, it was continued. It was documented in Care Connect as continuous CBD per home regimen. And he got over his sepsis. He went home. He came back 2 days later in status. And 2 days later, he was dead. Continuing the extract the entire time. So did the extract kill him? I doubt it. Can we say that it's safe? No. May it have complicated our management of his care? Maybe. But we'll turn back the clock a little bit. So when he first came in for that first sepsis admission, we did an overnight video EEG, and lo and behold, he didn't have a single seizure. So he was either having a good day, despite having a life-threatening infection, which is simply what we don't usually see. So I'm not sure what happened. I don't know what to think about this case, but he's another one where we have some video EEG evidence suggesting benefit, and we have to wonder whether he would have been better had we tried that therapy earlier in the course. I emailed Cory Booker, and he did not reply. Carlos.
Just a quick comment about the inpatient case. This comes to our M&M committee periodically, and by looking the other way, that may be the choice most of us are taking, but it's pushing some of the dilemma to the nurses, who will have some regulation about what they should do with home medication, and it puts them in a difficult position because we've sort of delegated our responsibility over it and let them deal with it.
Absolutely, and everyone's license is at risk, I would say. Okay. Okay, now we've got an 8-year-old with super refractory infantile spasms. You know, most kids with infantile spasms stop having those seizures around age 2 or 3. But a select unlucky few will continue to have those seizures for years and years and years. And this is one of those cases. So she came in to follow up with more than 40 seizures per day, including daily drop attacks. She technically qualified for Lennox-Gastaut syndrome. Her mother asked if I would recommend a CBD-enriched extract based on what she's read online and what Sanjay Gupta said, especially since she's clearly failed every single therapy I've recommended since she was born. You're outpatient, so you don't need to worry about these inpatient regulations. Anyone feeling bold? I was not feeling particularly bold. My sense was that even if CBD is effective, this is probably not a great candidate, that she is unlikely to respond to any effective therapy at this point. But that's maybe being pessimistic. But she's having 40 seizures a day. She's having lots of drop attacks. She's falling. She's hitting her head. She's wearing a helmet. She has no great life. So I can either do it myself and incur those risks and incur the wrath of risk management. I will make no mistake, they will not be happy if you write a quote-unquote recommendation for medical marijuana. You could pass the buck. There are plenty of physicians who are less scrupulous than the people in this room who will write that recommendation and get this product to the patient for a small fee. You could try to get her into a phase 3 clinical trial that is coming soon, quote-unquote, using a known quantity in an FDA and DEA sanctioned environment, totally legal, but you have to wait for it. You could also prescribe something else that you think has little hope of working. Anyone going to commit?
I want to question your use of the word less scrupulous than the people in this room. You're presenting pretty complex issues. There are the ethical issues, there are the legal issues, there's harm, and there's, helping the patient. And, when you're presented with a patient like this, what do you have to offer this patient? As you said, you don't have anything to offer. So I may not be a physician who would choose to prescribe medical marijuana. First of all, I have no expertise, so what's the dose? I wouldn't know how to do it. But I wouldn't necessarily describe someone who chooses to do it, who has some expertise in it, as someone who is not, scrupulous.
Yeah.
So that's my question.
And I was teasing you because I didn't want you, I wanted you to be extra bold in choosing choice A. And I got to tell you, I kind of wish I chose choice A, but I chose choice C. Maybe because I'm maybe a little bit selfish, that I wanted her to get into this trial and get some data that could be definitive, that could maybe help her, that could help the entire epilepsy community. But that study wasn't ready to go. and she died the very next day. Okay, so she died of something called SUDEP, or sudden unexplained or unprovoked death in epilepsy. And this is common among kids who have highly refractory epilepsy. It's even more common in kids and young adults who have frequent convulsive seizures. I say common, it's not that common overall, but the frequency of death with epilepsy is enriched in those with terribly severe epilepsy. So none of these have a right answer, and no matter what you do, you are exposing yourself to some legal liability, whether it's the wrath of UCLA, whether it's local DEA. We're in a bind, and if I can impress any advice on you, is that we have to do what's in the best interest of the patient. First and foremost, whether or not that exposes us to legal risk, whether or not that exposes the hospital to legal risk. And at the end of the day, my guess is that we will be largely protected if we make decisions in the interest of the patient. And even if you do things that are legal or scrupulous, if it is imparting harm to that patient, it will not end well. And above all, we need to complete these studies so we can finally figure out if these substances are effective and safe, and we need to do it quickly. Okay, that's it. Any questions? Front.
You talked about the expense of these products, and I think kind of a certain education level that makes you kind of research these products. I'm wondering in what way that limitation biases the study, and that it almost selects for a certain demographic that can have access to this or
Absolutely. So the patients who are getting into most expanded access studies across the country tend to be more sophisticated. They tend to be connected. Patients, frankly, have to compete to get into these studies. When we think about most clinical studies, we're worried about recruitment, that we can't get enough patients into these studies. Last I looked at our list, we had 275 patients competing for 25 spots. We have to actually meet in the next couple of weeks to narrow that list. And how you go about choosing patients for a compassionate use study, it seems crazy. If we're acting in a compassionate way, we should be offering that compassion on an equal basis to as many patients as possible. But the reality is that we simply can't do it. And although there are hundreds of patients on this protocol now, there's been some pushback from the FDA to limit the enrollment, because you can't just keep treating patients on a compassionate use basis with a substance with no proven efficacy and safety. Claudia.
Shaun, I appreciate the challenges for you with pediatric neurology as well as with family. I have to say, personally, I've been in all these cases, and I've been open to alternative treatments and uses of agents. I think what's going to be helpful is looking at clinical studies and research across the country at all these institutions and seeing the efficacy, and then being proactive and establishing guidelines and protocols to protect the patient, the family, plus the institution and us ourselves to utilize these agents. At the end, in what's the best interest of the child. I can imagine when I do this with my kids. It's tough.
And I will tell you, there are 3 UCLA faculty parents who are on these products, these illegal products. So don't think that these are less sophisticated, unintelligent parents. These are actually very intelligent parents who don't have our same medical expertise and perspective, but the vast majority have done their homework. Before we proceed, there was one question earlier about whether it's safe to stop these products in the hospital. And my guess is it's probably not safe to stop them. And we presented this conundrum to the UCLA Ethics Committee, and they have supported us in saying that we would be reasonable in continuing an illegal product if we believe it is in the best interests of the patient, and if we believe there's a potential for a threat to that patient's health or life. Sankar.
I think the FDA has a class warning in all the package inserts for approved seizure meds that you should not stop the program. Of course, the FDA hasn't approved this particular one, but that's considered a class warning. So you could make a case that
One more back.
Isn't the restriction really on THC, not so much on cannabinoids?
It is not. So the restriction is on marijuana and all constituents of marijuana, THC, CBD, and every other cannabinoid. And that is it doesn't make a lot of sense. And the way to fix it is to approve the CARES Act, which declassifies all marijuana or reclassifies it as Schedule 2 and divorces cannabidiol from the label marijuana. But it's not happening. Actually, so Senator Feinstein, I think, is probably in favor of it, even though she doesn't say so. And she published her letters that she wrote to the Department of Justice and the Department of Health Services, HHS, I'm forgetting what it stands for. But HHS said they were supportive of efforts to reclassify marijuana. The Department of Justice said they were not. And this is in spite of the White House and the U.S. Attorney General advising the DEA not to target people who are using marijuana for medical purposes. I think that's it. Thank you.
So thank you very much.